We shall now go on to our next speaker, Dr. Shikha Bassi, who's a Deputy Director of Neuro Ophthalmology Department based at Shankar Netralaya, Chennai. And she is going to talk to us another very important topic, OCT and OCT angio in neuro ophthalmology.
Thank you, ma'am. Am I sharing the screen?
Yeah. Yes.
Yeah. So, at the outset, I would like to thank Chitra madam for inviting me to give this talk on OCT and OCT angiography in neuro-ophthalmology. I will not be going into the basics of OCT or the protocols, what protocols are used, but I would like to share as many clinical cases from neuro-ophthalmology where the OCT can be used as an adjunct. So congenital optic, starting with basics, that is congenital optic disc anomalies. Let me share a case of bilateral disc edema, which was an incidental finding in an elderly gentleman who had come for a cataract surgery. So the visual fields were normal in both the eyes, and the RNFL layer showed a little bit of thinning. And what is most important here is that the patient had these discrete lesions, structures, the hyporeflective lesions with hyperreflective margins in the substance of the optic nerve in both the eyes. So, which confirmed the diagnosis of optic nerve head drusen, and the patient safely underwent the cataract surgery. The optic nerve head drusen on OCT has been studied in detail by the Optic Disc Drusen Study Consortium, which has defined these structures as hyporeflective structures always located above the lamina cribrosa with a full or a partial hyperreflective margin as seen here, and most prominently superiorly. Not every patient with pseudopapilledema, we are able to see the drusen. Especially in children, what we see is peripapillary hyperreflective ovoid mass-like structures. And we've published this here. In case of true papilledema, there is a lot of shadowing. And in case of crowded small discs, certain times all we see is a forms, that is peripapillary hyperreflective ovoid mass-like structures, which are basically herniating optic nerve fibers, and they herniate out because the disc is small because of the paucity of space. Another congenital optic disc anomaly is disc pit, which is not very difficult to diagnose clinically. But if you want to confirm, you can literally see the excavation on the OCT, and in a wide field OCT, SSOCT, you can see these skytic spaces, which may be associated with the pit because of the pit maculopathy. Morning glory syndrome, again, not difficult to diagnose, but you can miss these subtle associated things. You can see the SRF. You can see these cystic spaces around forms-like structure, which is not actually the forms. It's an active CNVM. You can pick it up on the OCT. We'll be going into the peripapillary CNVM in detail when I go to the OCT angiography. Now, this is a case of optic disc coloboma. It's basically a very large disc. And how does one confirm optic disc coloboma? You can see that this is choroidal coloboma. This is not actually the disc. You can see the RNFL is sitting right over the choroid. So something similar is happening at the edges here, and this is a normal disc. And this is the colobomatous disc. So these features have been well defined, and if you are in doubt, you can order OCT and confirm the diagnosis. This is a patient with coloboma with a disc pit. So these are very subtle things. If you can diagnose clinically, well and good, but you can confirm by doing OCT. In case of hypoplastic disc, the disc size can be quantified on the OCT. You can see the RNFL thinning in 2 or 3 quadrants, and again confirm the diagnosis. Now, in cases of acute optic neuritis, in the acute phase, there is thickening of the peripapillary retinal nerve fiber layer, and this over a period of 4 weeks sets into thinning, which is more prominent in the superior and inferior quadrants. And this thinning is more prominent in superior and inferior quadrant in case of NMO spectrum disorder, and it does not correlate exactly with the visual function of the eye. What correlates with the visual function is the macular ganglion cell IPL layer thickness, and it becomes thin and around 2 weeks later after the attack, which is much earlier than the RNFL thinning. Another tip is that this thinning is very severe in case of NMO spectrum disorder optic neuritis. Let's look at some cases. This is a case of MS optic neuritis. In acute case, there is thickening of 2 quadrants. The RNFL is thickened, but there is thinning in the other eye. And this is an evidence of dissemination in space and time. This can also be used, OCT can also be used to provide evidence that there is no activity. If the OCT RNFL thickness is remaining same, then one can say that there is no disease activity, active disease activity. As I said previously, in NMO spectrum disorder, the RNFL thinning is occurring in the superior and inferior quadrants. In case of, now let's look at the GCC layers. Same 2 patients, MS optic neuritis and NMO spectrum disorder. In acute case, there is nothing much happening in this layer in the right eye, but the left eye, which has had a past attack, there is evidence of thinning of the GCC layer. And in NMO spectrum disorder optic neuritis, there is severe thinning afflicting all the sectors. In severe cases of optic neuritis, be it NMO spectrum disorder or MS optic neuritis, there can be associated microcystic macular changes. And this is because of the retrograde axonal degeneration and loss of retinal Muller cells. Now, another important thing is that in case of multiple sclerosis, even if the patient has not had an attack of optic neuritis, there will be peripapillary retinal nerve fiber layer thinning, which is very much similar to that of Alzheimer's and Parkinson's, all the degenerative brain diseases. But in case of NMO spectrum disorder, this thinning is attack related, not progressive like multiple sclerosis. Can RNFL thickness be used to diagnose the tumors? Let's look at this example. Here, the RNFL thickness is almost normal in one eye, and visual fields giving much more information. So obviously, it's not that reliable. Fields more important, but GCC layer thickness is very much similar to that of the visual fields. Here, you can see it's correlating very well with the visual fields. The left eye is completely gone, and here a GCC loss is seen like a hemianopic defect. So patients where it cannot be, they cannot do visual fields, GCC can be used to monitor these patients of brain tumors. So we can prognosticate the visual outcome after the neurosurgery. In cases of ischemic optic neuropathy, the cupless disc can be seen, and presence of subfoveal fluid can be picked up, which can tell us that the patient will eventually regain vision once this fluid is absorbed. Now, I'm not going into the details of ischemic optic neuropathy. I would like to cover a little bit of OCT angiography. So in OCT angiography, what we are able to see is the peripapillary radial capillary network and also the choriocapillaries. But the disc edema is something which, makes it difficult to visualize this layer. I would like to share one case of chronic uveitis with disc edema and hemorrhage. This patient had chronic uveitis, diabetic, proliferative diabetic retinopathy, and patient was referred to me for disc edema and this little bit of hemorrhage, but there's not in the visual fields a little bit of enlargement of the blind spot, and this is what the patient had. So this lady had a active peripapillary CNVM, which could be diagnosed easily because of the OCT angiography. Similarly, this gentleman, he presented to us with optic disc drusen's, which could be seen, but there was again this macular scarring. Then the visual field is poor because of the optic disc drusen associated RNFL thinning. But again, OCT angiography could pick up the peripapillary CNVM. So this is how I use OCT angiography in the neuro-ophthalmology practice. This is a very beautiful paper. Yeah, just want to sum it up with this very beautiful paper regarding the use of OCT angiography in ischemic optic neuropathy, papillitis, and papilledema. And the paper says that in ischemic optic neuropathy, there is an area of vascular dropout which can be seen, vascular tortuosity can be seen, and severe disappearance of the peripapillary regular pattern is seen. In case of papillitis, there's no vascular dropout, radial distribution of the peripapillary capillaries remains preserved, and there's moderate alteration of the peripapillary regular pattern. Whereas in case of papilledema, you see a tangled ball of vessels and there's no vascular dropout. So with that, I'll conclude.
Thank you, Dr. Shikha. There was a wonderful talk and so much of learning, and all my questions got answered. And we are to take Murli, any question from you, or do we go on? Murli, unmute yourself.
I have a question on OCT angiography. So in the acute stage of ischemic optic neuropathy, usually there will be some edema. So do we wait for some time before doing the OCT angiography, or would you recommend a serial OCT angiography? What do you do in your clinical practice?
Yeah, that's what Murli. I've just shared the paper. I have OCT angiography in my clinical practice. I'm not using it for ischemic optic neuropathy as yet. I've just shared that paper. For this very reason, that in acute cases, the segmentation becomes very difficult. The optometrists who do we've tried it because of the disc edema. Even if they manually try to do the segmentation, it's very difficult to do it. And then if you don't do the segmentation properly, you're not going to pick up the capillary dropout area. So it needs to be done. I agree that in case of acute disc edema, it becomes difficult. Yeah, in later stages, definitely. But then if you have to plan your treatment, it's most important that you diagnose the condition in acute situation.
Thank you. Thank you, Dr.